I'd like to present to you Professor Elizabeth Molyneux, who is the Honorary Professor of Pediatrics, College of Medicine, University of Malawi, and Blantyre. Please welcome her up. Welcome. I think we were all on alert when the FEAST trial came out a couple of years ago in the New England Journal of Medicine, where the mortality was increased after a bolus dose. In those children that got a bolus dose had an increased mortality in comparison with the control persons. And I think the next session will maybe shed light on that as well. I would also like to introduce Dr. Roberta Petrucci. She has a lot of experience with MSF in different settings and missions, and she's now part of the Medical Operations Support Unit in MSF Geneva. Please welcome her. Thank you very much. Okay, welcome.
Thank you, ladies and gentlemen, and it's a great honor for us to chair this particular session, because I think we're all very passionate about how we care for very sick children, and yet perhaps what we thought we knew has been turned on its head to some extent in shock. You've got here, I think, some of the world's most well-known and doyens of pediatric shock, and they're going to speak to us. They come from different backgrounds. So we've got Joe, our first speaker, who works in the States. He's very high-tech. And then we've got people who work in low-income settings. And I think we have to remind ourselves that doing the best for a child is not always doing the best that is possible, but the best that is for that child in that situation, given that environment, with the experience and staff that you've got with you. So bear that all in mind, because I think you also come from different places, different positions in your career. Some of you work in high income, some in low, some in both. Some of you want to go and work somewhere else. And this is a chance to really hear some of the interesting stuff behind it all. So we're going to start with Prof. Joe Carcillo. He's a doyen of shock. He comes from Pittsburgh. He's in the critical care unit there and has led the way for high-income setting management of critically ill children. Joe.
Thank you. Thank you for inviting me. It's a wonderful honor, one of the finest honors I've had, actually. So I can think of no greater audience to share this with, because you're in the unique position to actually use all the information I'm giving you today. Actually, that never happens, because I have more information than people can use. Okay, so the way that we think of in the Global Pediatric Sepsis Initiative, which is kind of a backwards approach because it's coming from intensivists giving their viewpoint on something that starts outside the intensive care, is that there are 3 models of sepsis. This comes from Dr. Levine's work, which will come in a bit. Dr. Levine has essentially pioneered 3 research units. One is in sub-Saharan Africa, where children endemically have malaria. The other is in Southeast Asia, where children endemically have dengue. And then the other is in the UK, where children do not have dengue or malaria. So when you look at how you resuscitate and treat sepsis, the first thing is if it's bacterial, you give antibiotics. So dengue is not a bacterial infection, it's a viral infection. It actually doesn't present with tachycardia, it actually presents with bradycardia. It doesn't present with a wide pulse pressure, it's actually a narrow pulse pressure. It's a pure capillary leak syndrome, and if you keep up with the capillary leak, the patients have near 100% survival. So in these patients, you give fluids because the mode of death is hypovolemic shock. And importantly, you have to follow electrolytes at the same time. If you have a SAM patient, for example, in the work we've done in South America, where they have SAM patients, meaning that they have protein malnourishment, they've actually found that it's better to give hypertonic saline rather than just pure saline. They get less capillary leak syndrome, less anasarca. When we look at malaria, malaria is not a capillary leak syndrome. Malaria, severe malaria patients have a plugging of their blood vessels, very much like what we have in the United States, which is going to be talked about this afternoon or tomorrow, sickle cell patients. So hemolytic anemias that result in shock or result in circulatory disturbance are doing it because of capillary plugging. And they're related with a severe anemia. So this is anemic shock. So if you take a dengue patient or an Ebola patient or a cholera patient, you'll see hemoconcentration, but when you take children who have severe anemic shock, you see the opposite. You see the hemoglobin or hematocrit. So this can guide you into which fluid you need. Blood if you're severe anemic, fluids if you're hemoconcentrated and dehydrated. And then there's something which I was informed about yesterday called mixed shock, but we call it septic shock. And septic shock is bacterial. And this is a combination of abnormalities. It is a combination of capillary leak syndrome, so you're hypovolemic. You're thrombotic, so you need fluids not only because you're hypovolemia, but because you're actually thrombosing off your kidney, your brain, et cetera. You have cardiac dysfunction, so you need inotropes. You have vasodilatation, so you need vasopressors. You have adrenal insufficiency, so you need hydrocortisone. But not all the children need the same thing. So you, as the clinician at the bedside, have to figure out what your patient needs. They don't all need the same thing. They don't all need the same amount of fluid. They don't need the same amount of inotropes. And the clear thing is, if you endeavor to treat these patients, you have to measure many things. And this brings us to why I think the MSF is the perfect place to talk about this. So the way that we see sepsis globally is from an administrative standpoint, not a pediatrician standpoint. And so I think the slide was showed earlier by Sahar, where she showed that mortality in the 1940s here was greater than 30 per 1,000. And that's what the mortality rate was when I was born in the United States of America. So I don't think that's that bad, honestly, because I certainly survived it. My family survived it. It doesn't mean that we have to stay there, but the point is that if you are in a community with greater than 30 deaths per 1,000 children, you're in group A. And here, we suggest the MSF that you bring immunizations, potable water, nutrition, zinc, vitamin A, and availability of intramuscular antibiotics through healthcare workers. So no doctors. Not Doctors Without Borders, but healthcare workers without borders. Now, when you go to the next level, where the mortality rates are actually less than 30 per 1,000, here we recommend that you bring experienced healthcare workers, possibly doctors, depending on what a doctor is in that community. But essentially, this is where you need to have access to IV fluids and antibiotics, oxygenators or concentrators, and availability of emergency clinics. And this is based on beautiful work which Kath will talk about, where she has 7% mortality in the malarial population with IV fluids, antimalarials, antibiotics. Beautiful work from Thailand, where when you use NP-CPAP in randomized trials, they reduce the need for intubation by 50%, reduce mortalities from pneumonia by 50%. And also, similarly, 4 studies in dengue, which had access to bubble CPAP, and then 40 mLs per kilo of fluid over an hour and a half, and their mortality was less than 1% for dengue shock, regardless of what fluid was used. Although Ringer's lactate was better because you resolved your narrow pulse pressure sooner. Now, the people that I work with mostly in research are people who are in C. And so for the MSF, you have to decide where your centers are or C. For example, when you go to Syria, Syria is C. Syria is not B or A. And you have to decide if you're trying to mimic the level of care that is in Syria already, or bring them a level of care that is less than they're used to. That's an administrative decision. But at this point, when you come to that, now you have to be able to provide time-sensitive antibiotics, fluid resuscitation, inotrope infusions, mechanical ventilation, and importantly, it should be available to everybody. That's our basic vision. Now, that doesn't mean that you're making available to all people in Syria, but if you decide you want a B-level project or a B-level hospital, you should have the resources to provide that. And then D is where we are. So let's bring it through quickly. Let's say we had a severe malarial patient. You were seen in level B, then that's the FEAST trial. If you're seen in my hospital in D, because we get, or used to get, a lot of Peace Corps children, we have no deaths from cerebral malaria. We exchange transfuse them. So at D level, you have extracorporeal therapies. So this is the general concept that I like to put forward to the MSF, is it's really not about protocols. It's not about what you do and don't do. It's about what level of care you're going to present with what resources. So we have bundles according to that level. The teaching of the IHI is that you want to have 3 to 4 element bundles. This is really the only thing you can expect to implement and have people do. So these bundles that we have is for Group A: vitamins, nutrition, potable water, village healthcare workers, intramuscular antibiotics. There's 3 large randomized cluster trials that have shown 6-fold reductions in mortality with this approach, particularly in newborns, the subject of tomorrow. In the malaria belt, establish IV access, begin maintenance intravenous fluids with glucose and sodium. The high level, you saw 60-some% level of hyponatremia in the past presenter. There's a lot of hypoglycemia, so you have to give glucose at the same time. Treat with your antimalarials and your antibiotics. Administer blood if your hemoglobin is less than 6, and there'll be plenty of speakers to talk about the FEAST approach. And in the dengue belt, you establish IV access, begin a fluid bolus with physiologic intravenous solution, Ringer's or Hartmann's. I think this in particular, from what I'm hearing, a lot of the projects do not have access to electrolytes, so I would suggest not using normal saline. Try and give something that's as balanced as possible. You titrate to normalizing hemoconcentration. So the average hematocrit of a patient in the dengue belt is 50. So the target is 30. And then also give high-flow nasal cannula and O2 and bubble CPAP. And in 3 randomized trials, including New England Journal of Medicine, the reduction in mortality, it's less than 1%. So really, tried and true approach. And then the septic shock patient, and here we're talking about if you're at level C and D, and you have all the things that you need to have to provide that care. You reverse shock and restore capillary refill in the first hour with a normal blood pressure, so you have to have a blood pressure cuff. You administer the proper antibiotic, and you give D10 and sodium-containing solution at maintenance to prevent hypoglycemia. And this is from our Vanguard studies, which in the interest of time, I can't show you all the data, but essentially you can reduce mortality 3 to 4-fold by implementing these bundles. For shock reversal in the developed setting, in the rich setting, we do it by providing fluid bolus, but if a kid's liver is down, has RALS, has pneumonia, it's not septic shock, we don't give a fluid bolus. And then we give up to 60 mLs per kilo, but we reassess the patient every time we give fluids. We start them on peripheral adrenaline and then transition to central adrenaline once we have the ICU going. And I'll show you the data on this, but at least in the United States, your mortality rates are 1.7% when you use this approach. And then in the PICU afterwards, we monitor shock by maintaining a central venous saturation greater than 70% and a perfusion pressure important for the brain and the body and the kidney that is normal for age. But for this, you have to be able to monitor. You have to have a blood gas machine, and you have to be able to monitor blood pressures. We use effective tidal volumes of 6 to 8 mLs per kilo if you're on a mechanical ventilator. And again, with this, we have a 2 to 3-fold improvement in survival. So what are we talking about when we talk about sepsis? There's infection with fever, say scarlet fever, strep throat. And many of thousands of children get this, but they don't have sepsis or septic shock. Sepsis has been defined for over 2,000 years. It's not a new concept. Sepsis means your body is rotting. That's what it means. So you get a cut, the child should come in, there should be some nidus of infection. So they say they had an infection. It should be Rubella or Dolar. But now after the Rubella or Dolar has spread, now the patient has fever, respiratory distress, and so on and so forth. Early signs are prolonged capillary refill, or in older children, this is the rich guys now, the resource-rich kids we're talking about. Their presentation is they can't walk. So they say, my legs hurt, I can't walk. That is a clear sign from Dr. Ninnis's work with Dr. Levine of septic shock. If you wait too long to treat the patients, then the only way they survive is this way, on mechanical ventilation. You can see there's severe thrombosis, you can see their organs are coming off, and so on and so forth, so you have to recognize early. Antibiotics are the cure. Now, antibiotics are the cure because pathogens double every, guess how many minutes? Less than 30 minutes. So if you wait 3 hours, you've doubled 3 times. That's a 6-fold increase. And it's clear, all the data shows the same thing. The longer you wait to give the proper antibiotic, the more chance of dying, the longer chance you're going to be in the ICU with a mechanical ventilator, the longer chance you're going to get multiple organ failure. So the only way that you can approach sepsis is you have to know the susceptibility of the germs in your community. So if you're putting an MSF center out there or project and you want to study sepsis, for 6 weeks or whatever, you need to get blood cultures. You need to send them to a microbiology lab, maybe it's in France or wherever it is. You do the susceptibility testing, and then you inform the physicians, these are the empiric antibiotic regimen that we're going to use in our children. If you just go out there and say, we're going to give Ceftriax on everyone, maybe it works, maybe it doesn't. So if you want to take a developed world approach, you have to know the susceptibility of the organisms because MDROs are everywhere, multiple drug-resistant organisms. So once you get that, then you can have a low-risk and a high-risk approach, and then you have your antibiotics set up, and then you can be organized to get them to the patients within an hour. Now, within your systems, you have to have a trigger tool. Trigger tool means that the nurse has a trigger tool that tells her, him, or the sister that tells her, him, that I need to get a doctor to decide if the patient has sepsis or septic shock. So there's no tool that tells you you have sepsis or septic shock. 2 minutes. Only what you yourself have as a physician. Once you implement that, this is the trigger tool that's used in the United States for patients who are in a resource-rich setting. Once you implement those, you can have time-sensitive delivery of fluids and antibiotics. It reduces renal dysfunction for the gentleman that asked about malaria. In addition to the fluids and antibiotics, you can start peripheral adrenaline if they remain in shock. And when you do that, you reduce mortality from 20% to 7%. When you apply these early guidelines in the first hour, it's not easy. You have to go to your setting. When you go to your setting, you'll see there is not initial compliance. It's difficult to do 4 things at once. You have to form an Ishikawa wishbone figure to evaluate whether or not the reasons that you're not succeeding are human interaction factors. And in this study, they found, for example, that it was the clock. If you went from 60 to 0, the parents and the doctors were frightened. If you went from 0 to 60, they weren't. So the fear that the patient was going to die if you got to 0 without your task being done was paralyzing. But if you went to 0 to 6, it was empowering. When we did our national study implementing this in U.S. emergency departments, we find a reduction in mortality from 11% to 3%. And when you look at the Dr. Hans-Jörg Lang's work, where he's done the same similar approach with the triage approach and physicians, et cetera, thinking locally, as my friend Andrew said, he found the same reduction in mortality as we did. So you too in MSF centers can accomplish the same thing. Thank you.